Good afternoon. This is the lecture for patients with colorectal cancer. Colorectal cancer is the third most common cancer diagnosed in the United States. Early diagnosis and improved treatment have improved the survival rate for those who have colorectal cancer. Its incidence, which is nearly equal among men and women, has been declining in the United States for the past 2 decades, primarily due to the improved screening. The incidence of colorectal cancer varies among ethnic groups. It occurs most frequently after age 50, and it continues to rise with the increasing age of patients. With early diagnosis and treatment, the 5-year survival rate for colorectal cancer is 90%. However, only 39% of colorectal cancers are actually diagnosed at such an early stage. Although the specific cause of colorectal cancer is unknown, there are a number of risk factors that have been identified. Colorectal cancer has an insidious onset, and symptoms do not appear until the disease is advanced. Regular screening is necessary to detect precancerous lesions. Approximately 1/2 of all colon cancers occur in the rectosigmoid area. And as you look at this slide here, it shows you all the different areas. The cecum for male and female, it's around 11 to 10%. In the ascending colon, 22 and 27%. Transverse colon for cancer, 11 and 13%. Overall, in the descending colon, it's 6% across the board. The sigmoid colon, 25 to 23%. And rectal cancers, 22 to 27%. When we look at the risk factors, there are some genetic factors that are linked to the risk for colorectal cancer. Up to 25% of people who develop colorectal cancer actually have a family history of the disease. Hereditary non-polyposis colorectal cancer syndrome, which is also called Lynch syndrome, is the most common inherited form of hereditary colorectal cancer. This is an autosomal dominant disorder that significantly increases the risk for developing colorectal and other cancers. Tumors associated with Lynch syndrome often affect the ascending colon and tend to occur at an earlier age. Inflammatory bowel diseases increase the risk of colorectal cancer as well. Diet plays a role in the development of colorectal cancer. The disease is prevalent in economically prosperous countries where people consume diets high in calories, meat proteins, and fats. This dietary pattern, which is very common here in the United States, is thought to increase the population of anaerobic bacteria in the gut. These anaerobes convert the bile acids into carcinogens. Diets that are high in fruits and vegetables, folic acid, and calcium appear to reduce the risk of colorectal cancer. Other factors that may also help reduce the risk include regular exercise, taking a daily vitamin, and the use of aspirin and other NSAIDs. Nearly all colorectal cancers that begin as adenomatous polyps or adenocarcinomas. Most tumors develop in the rectum and the sigmoid colon, although any portion of the colon can be affected. The tumor typically grows undetected, producing few manifestations. By the time manifestations occur, the disease may have spread into deeper layers of the bowel tissue and adjacent organ. Colorectal cancer spreads by direct extension to involve the entire bowel circumference, the submucosa, and outer bowel wall layers. The neighboring structures, such as the liver, greater curvature of the stomach, duodenum, small intestine, pancreas, spleen, genitourinary tract, and abdominal wall, also may be involved by direct extension. Metastasis to regional lymph nodes is the most common form of tumor spread. This is not always an orderly process. Distal nodes may contain cancer cells, while regional nodes remain normal. Cancerous cells from the primary tumor may spread by way of the lymphatic system or circulatory system to the secondary sites such as the liver, lungs, brain, bones, and kidneys. Seeding of the tumor to other areas of the peritoneal cavity can occur when the tumor extends through the serosa or during surgical resection. Bowel cancer often produces no manifestations until it is advanced. Because it grows slowly, 5 to 15 years of growth may occur before actual manifestations develop. The manifestations will depend on the actual location, type, and extent of the tumor, as well as the complications that the tumor can cause. Rectal bleeding is often the initial manifestation that prompts a patient to seek medical care. Other common early manifestations include a change in bowel habits, either diarrhea or constipation. Pain, anorexia, and weight loss are characteristic of an advanced disease. A palpable abdominal or rectal mass may be present, and occasionally the patient presents with anemia from occult bleeding. This slide shows some of the symptoms of cancerous lesions. Again, rectal bleeding is the most common reason that people seek medical attention. They can have alternating constipation and diarrhea. A lot of times the patient will experience diarrhea as the stool is evacuating around a large tumor, so it's just the watery aspects of the stool. Again, a change in the stool caliber, again, that goes in with the obstruction of the tumor where they can be narrow and ribbon-like. The patient may also at times feel like they have not completely evacuated their bowels. And then, of course, we can have an obstruction that occurs. As mentioned earlier, these patients can come in and they will be anemic from the bleeding that has been going on. And a part of the complications that can occur that are associated with colorectal cancer include a bowel obstruction due to the actual narrowing of the bowel lumen by the tumor itself. Also, the patient can have a perforation of the bowel wall that can occur by the tumor, which allows contamination of the peritoneal cavity by the actual bowel contents. And then they can also have a direct extension of the tumor to involve adjacent organs. Most recurrences of colorectal cancer after tumor removal occur within the first 4 years. The size of the primary tumor does not necessarily relate to long-term survival. The number of involved lymph nodes, penetration of the tumor through the bowel wall, and tumor adherence to adjacent organs are better predictors of the prognosis for the disease. We're now going to look at a case study involving a gentleman, G.O., who is 65 years old. He's been admitted for a colon resection after being diagnosed with colorectal cancer. At the time he is admitted, he complains of constipation, bloody stools, abdominal pain, and weight loss. He is 6'1" and weighs 200 pounds and smokes 1 pack of cigarettes per day. He also has a history of coronary artery disease and hypertension. He reports taking antihypertensive medication, and also he takes 81 milligrams of aspirin daily. He wants to know how he got colon cancer. So let's think about this. In reviewing his history and what you know, what risk factors does he have? The first is that he's 65 years of age. He is 200 pounds and he smokes a pack of cigarettes a day. And he is of male gender, which puts him at higher risk for developing colorectal cancer. This slide shows us the signs and symptoms of colorectal cancer by the location of the primary tumor. When we look at the ascending colon, the patient will have pain, there can be a mass present, they will have change in bowel habits, and they will come in and be anemic. When we look at the transverse colon, the patient can have pain, they can have an obstruction that occurs with changes in their bowel habits, and again, anemia. When you look at the descending colon, the patient will have pain, a change in their bowel habits, they will have bright red blood in their stool, and they can develop an obstruction because of the tumor. In the rectum, they will have blood in the stool, as well as change in their bowel habits, and they will experience rectal discomfort as well. Diagnostic and laboratory tests are used for screening, diagnosis, and monitoring purposes. Diagnostic tests include a sigmoidoscopy or colonoscopy as the primary diagnostic test used to detect and visualize tumors. While flexible sigmoidoscopy can detect 50 to 65% of colorectal cancers, many clinicians recommend colonoscopy. Tissue for biopsy is obtained at the time of the endoscopy to confirm cancerous tissue and evaluate cell differentiation. Current staging methods primarily use the TNM system that was outlined for you in the oncology chapter. Radiologic examinations may include a chest X-ray to detect any tumor metastasis to the lungs. A CT scan or MRI or ultrasonic examination may also be used to assess tumor depth and involvement of other organs by direct extension or metastasis. Laboratory tests utilized are the fecal occult blood by guaiac or hemoccult testing to detect if there is blood in the feces, a CBC to detect anemia that results from chronic blood loss and tumor growth. Carcinoembryonic antigens, or CEAs, are tested as a tumor marker that can be detected in the blood of patients with colorectal cancer. CEA levels are used to estimate prognosis, monitor treatment, and detect the recurrence of cancer. Beginning at age 50, both men and women at average risk for developing colorectal cancer should undergo screening tests to detect both polyps and cancer according to one of the testing schedules above. When we go back, they should either have a flexible sigmoidoscopy every 5 years, a colonoscopy every 10 years, a double contrast barium enema study every 5 years, or CT colonography every 5 years. Colonoscopy is the gold standard for screening of colorectal cancer because using the colonoscopy can actually examine the entire colon. Again, the biopsies can be obtained and polyps can actually be immediately removed and sent for laboratory examination. Those who are at risk, please review Table 4321 for risk factors dealing with colorectal cancer. Should actually begin screening earlier and have screening done more often. Those who have a first-degree relative who developed colorectal cancer before age 60, or who have two first-degree relatives with colon rectal cancer, should have a colonoscopy every 5 years, beginning at age 40 or 10 years earlier than the youngest relative who developed cancer. However, those who have one first-degree relative who had colorectal cancer after age 60 should have the same screening as the average at-risk person. Once colonoscopy and tissue biopsies confirm a diagnosis of colorectal cancer, additional lab studies are done, again including the CBC. They will also have coagulation studies and liver function tests. The CT and the MRI will also be done, or may be done, to look and see if there has been any liver metastasis, retroperitoneal, and or pelvic disease. It will also help to determine the depth of the penetration of the tumor into the bowel wall. However, please keep in mind that liver function tests may be normal even when there has been metastasis to the liver that has occurred. Again, talking about the carcinoembryonic antigen, this is a complex glycoprotein, sometimes produced by colorectal cancer cells. We do use this to help monitor for the disease, whether it has recurred after surgery or chemotherapy. But again, we have to keep in mind that there can be false positives with this test. The prognosis and treatment of colorectal cancer actually correlate with pathologic staging of the disease. The most commonly used staging system again is the tumor node metastasis, or the TNM staging. Your table is also here in 4323. Please review this and be familiar with it. As with other cancers, prognosis worsens with greater size and depth of the tumor, if there is lymph node involvement, and if there has actually been metastasis that has occurred. This slide actually shows the different stagings of colorectal cancer. When we talk about a stage 0, the cancer has not grown beyond the inner layer of the colon wall. In stage 1, as you can see here, it has actually grown to the outer layer of the wall. In a stage 2, the tumor is actually through the wall, but it has not spread to the lymph nodes. A stage 3 has actually spread to the lymph nodes, as represented by the little yellow in each of the lymph nodes. A stage 4 cancer has actually spread on to distant sites and metastasized to areas such as the liver or the lung. Surgical resection of the tumor, adjacent colon, and regional lymph nodes is the treatment of choice for colorectal cancer. There are many options for surgical treatment that vary from destruction of the tumor by laser, which can be performed during endoscopy, to an actual abdominal peritoneal resection with a permanent colostomy. When possible, the anal sphincter is preserved and the colostomy is avoided. In laser photocoagulation, this uses a very small, intense beam of light to generate heat in tissues where it is directed. The heat generated by this laser beam can actually be used to destroy small tumors. It is also used for palliative surgery of advanced tumors to remove obstruction. It can be performed endoscopically and is useful for patients who cannot tolerate major surgery. Some polyps can actually be removed during colonoscopy, whereas there are others that may require surgery. Polypectomy during colonoscopy can be used to resect colorectal cancer in situ and is considered successful when the resected margins of the polyp are free of cancer. The cancer is well differentiated and there is no apparent lymphatic or blood vessel involvement. For other surgical treatment options for small localized tumor include local excision and fulguration. Again, these procedures can be done during endoscopy, such as the polypectomy. Local excision may be used to remove a disc of rectum containing a tumor in patients with a small, well-differentiated, mobile polypoid lesion. Fulguration or electrocoagulation is used to actually reduce the size of some large tumors, again for those who are poor surgical risk. It may require general anesthesia and may need to be repeated at intervals. Most patients with colorectal cancer undergo surgical resection of the colon with anastomosis of the remaining bowel as a curative procedure. The distribution of regional lymph nodes determines the extent of the resection because these may contain metastatic lesions. Most tumors of the ascending, transverse, descending, and sigmoid colon can be resected. Tumors of the rectum usually are treated with an abdomino-perineal resection in which the sigmoid colon, rectum, and anus are removed through both abdominal and perineal incisions. A permanent sigmoid colostomy is performed to provide for elimination of feces. Before surgery can be done, there needs to be a reduction of colonic bacteria before surgery. This is usually done by using a bowel cleanse and oral antibiotics. This helps to prevent any anastomotic leakage of bacteria and decreases the risk of postoperative infection and abscess formation. The bowel is typically cleansed with a polyethylene glycol lavage such as Go Lightly or Miralax, and the oral antibiotics used are normally neomycin and erythromycin to help cleanse the bowel. The site of the colorectal cancer will actually dictate the site of the resection, whether it is a right or a left hemicolectomy. Surgical removal of stage 1 cancer includes removal of the tumor and at least 5 centimeters of intestine on either side of the tumor, plus removal of nearby lymph nodes. The remaining cancer-free ends are sewn back together. Laparoscopic surgery is sometimes used for stage 1 tumors, especially those in the left colon. Low-risk stage 2 tumors are treated with wide resection and reanastomosis, but chemotherapy is used in addition to surgery for high-risk stage 2 tumors. Stage 3 tumors are treated with surgery and chemotherapy. Once the cancer has spread to distant sites, surgery is palliative and chemotherapy is directed at controlling the spread. Radiation may also be used to help provide pain relief. If a patient has a perforation or peritonitis or is hemodynamically unstable, a temporary colostomy may be done, and then at a later time, the ends of the colon can be surgically reconnected. Let's go back to our case study. So now our patient is going to have abdominal surgery for his stage 1 tumor. What is the priority of care for this patient before surgery? You have to think back about his history as well when you're talking about this. We need to make sure that his hypertension is managed. And in regards to the current condition, he needs patient teaching, he needs pre-op teaching for what to expect post-operatively, and he needs emotional support as well. Surgical resection of the bowel may be accompanied by a colostomy for diversion of fecal contents. A colostomy is an ostomy made in the colon. It may be created if the bowel is obstructed by a tumor as a temporary measure to promote healing of the anastomosis, or it can be a permanent means of fecal evacuation when the distal colon and rectum are removed. Colostomies take the name of the portion of the colon from which they are formed. Ascending colostomy, transverse colostomy, descending colostomy, and sigmoid colostomy. A sigmoid colostomy is the most common permanent colostomy performed, particularly for those who have cancer of the rectum. It is usually created during an abdominoperineal resection. The procedure involves the removal of the sigmoid colon, rectum, and anus through abdominal and perineal incisions. The anal canal is closed and a stoma formed from the proximal sigmoid colon. The stoma usually is located on the lower left quadrant of the abdomen. When a double barrel colostomy is performed, two separate stomas are created. The distal colon is not removed but bypassed. The proximal stoma, which is functional, diverts feces to the abdominal wall. The distal stoma, also called the mucus fistula, expels mucus from the distal colon. It may be pouched or dressed with a 4x4 gauze dressing. A double barrel colostomy may be created for cases in which the patient has suffered a trauma, tumor, or inflammation, and it could be temporary or it could be permanent. An emergency procedure used to relieve an intestinal obstruction or perforation is called a transverse loop colostomy. During this procedure, a loop of the transverse colon is brought out from the abdominal wall and suspended over a plastic rod or bridge, which prevents the loop from slipping back into the abdominal cavity. The loop stoma may be opened at the time of surgery or a few days later at the patient's bedside. The bridge may be removed in 1 to 2 weeks. Transverse loop colostomies are typically temporary. In a Hartmann procedure, this is a common temporary colostomy procedure. The distal portion of the colon is left in place and is oversewn for closure. A temporary colostomy may be done to allow bowel rest or healing, such as following tumor resection or inflammation of the bowel. It also may be created following traumatic injury to the colon, such as a gunshot wound. Anastomosis of the several portions of the colon is delayed because bacterial colonization of the colon would prevent proper healing of the anastomosis. About 3 to 6 months following a temporary colostomy, the colostomy is closed and the colon is reconnected. Patients with temporary colostomies require the same care as those patients who have a permanent colostomy. We have touched on this a little bit, but I'm going to go into a little bit more detail here. There are 3 major options that surgeons can look at when it comes to a patient with rectal cancer. They can do either a local excision depending on the size, depth, and extent of the tumor, the abdominal perineal resection that we've already talked about that then will have a permanent colostomy, or they can do a low anterior resection to preserve the sphincter function for the patient. Once again, the decision is made based on the location and the staging of the cancer and the ability to restore normal bowel function and continence. Most patients with rectal cancer will require an abdominal perineal resection or a low anterior resection. The low anterior resection is used more often because of the potential for a more normal control over defecation. However, when the tumor is not resectable or there is metastasis present, palliative surgery is done to help control hemorrhage or to relieve a malignant bowel obstruction. Chemotherapy can be used postoperatively as adjunctive therapy for colorectal cancer. It can be combined with radiation therapy as well. When done this way, it can reduce the rate of the tumor's recurrences and prolongs the survival for patients with stage 2 and stage 3 rectal tumors. The benefit for colon cancers is less clear, but chemotherapy may be used to help reduce its spread to the liver and prevent recurrence. So let's go back and talk about our case study a little bit more. Gio is very upset. He has many questions about his diagnosis and his upcoming surgery. What interventions are appropriate to help alleviate his stress? For one, we need to listen to his concerns and the questions that he has. We talk to him again about the procedure and what he can expect following surgery. We elicit information about his support system and encourage him to have those people close by and available during this time. There are a variety of target therapies that can be used to treat metastatic colorectal cancer. Angiogenesis inhibitors, which actually inhibit the blood supply to tumors, are very useful for colorectal cancer. Some of the multikinase inhibitors actually inhibit or block several of the enzymes that promote cancer growth and can be used as well. There's also chemotherapy or target agents that block the epidermal growth factor receptor, and these are often used in the treatment of metastatic colorectal cancer. Although radiation therapy is not used as a primary treatment for colon cancer, it is used with surgical resection for treating rectal tumors. Small rectal cancers may be treated with intracavitary, external, or implantation radiation. Rectal cancer has a high rate of regional recurrence following complete surgical resection, particularly when the tumor has invaded tissues outside the bowel wall or regional lymph nodes. Pre- or post-operative radiation therapy reduces the recurrence of pelvic tumors, although the effect of radiation therapy on long-term survival is less clear. It can be used preoperatively to actually shrink large rectal tumors enough to permit their surgical removal. When we look at nursing management, one of the big things is our nursing assessment. If you will please review Table 4325, this reviews important information that needs to be gotten from your patient. We need to know about their any past health history, if they've had previous breast or ovarian cancer. Do they have familial polyposis in the family? Have they ever had a villus adenoma? Any polyps? Or do they have a history of inflammatory bowel disease? What medications are they on? Have they experienced any weakness or fatigue? Any change in their bowel habits? What's their dietary intake? What kind of foods do they eat? Do they eat a lot of processed meat? High fat and not enough fiber in their diet? Have they had problems with increased flatus? And do they ever feel like they have not completely evacuated their bowel? So, what does Gio need to know about how smoking can affect his health? We need to let him know that smoking actually increases GI motility and may influence his nutrition and dietary regimen and tolerance. He needs to know that this also adds risk to his existing cardiovascular condition, so we need to make sure that he gets information about smoking cessation and encourage him to quit smoking. Our overall goals in nursing are to make sure or try and have our patient have a normal bowel elimination pattern post-op, to have quality of life that is appropriate to the disease progression, that their pain is relieved, and that they have an overall feeling of comfort and well-being. When we look at health promotion, primary prevention of colorectal cancer is a significant nursing care issue. We need to teach our patients the importance of maintaining an optimal weight and staying physically active. We need to discuss dietary recommendations that are provided by the the ACS for the prevention of colorectal cancer. These recommendations include decreasing the amount of fat, refined sugar, and red meats in the diet, while increasing the intake of dietary fiber. Foods that contain high amounts of fiber include raw fruits and vegetables, legumes, and whole grain products. We also need to stress the importance of regular health exams, including digital rectal exams. We also need to discuss recommendations for regular hemoccult testing of stool after age 40. And also include the importance of seeking medical treatment if they notice any blood in the stool, and teach the patients the warning signs for cancer, including those specific to bowel cancer, such as a change in bowel habits. Endoscopic and radiographic procedures can only reveal polyps when the bowel has been adequately prepared to eliminate stool. Provide teaching to your patient about the bowel cleansing for outpatient diagnostic procedures, and make sure that the patient, when in the hospital, receives all of their cleansing preparations. Generally, the patient is placed on a clear liquid diet for 24 to 48 hours before they have their procedure, and they are given 4 liters of the oral polyethylene glycol lavage solution the evening before the procedure. Because many people find the lavage solution difficult to drink and may experience nausea and bloating, manufacturers have actually modified the solutions to improve their taste and palatability. Magnesium citrate solution or biscadiol tablets are sometimes given before the lavage solution to help remove bulk stool. Encourage your patient to drink all of the solution, as this will provide them with a better test and keep them from having to repeat the bowel cleansing again. Acute nursing care for a patient who's had a colon resection is similar to any care of the patient having a laparotomy. If the cancer was resected and the ends anastomosed, bowel function is maintained and routine postoperative care is appropriate. Inform patients about prognosis and future screening. Provide support for dealing with the diagnosis of cancer. Patients who have had an abdominal perineal resection will have a permanent colostomy or ostomy, and they will need emotional support to cope with their prognosis and the radical change in the body appearance and function. Patients with more extensive Surgery may have an open wound and drains, and a permanent stoma. Postoperative care includes sterile dressing changes, care of the drains, and patient and caregiver teaching about the stoma. Consult with a wound ostomy and continence nurse before surgery to help select the ostomy site on the abdomen and then provide follow-up care and teaching for the patient. A patient who has an open and packed wound requires meticulous postoperative care. Dressings need to be reinforced and they need to be changed frequently during the first several hours post-op when drainage is likely to be profuse. Carefully assess all drainage for amount, color, and consistency. The drainage is usually serosanguinous. Examine the wound and record if there's any bleeding, excessive drainage, or any unusual odor. Always use aseptic technique with dressing changes. If the patient's wound is closed or partially closed, the incision needs to be assessed for integrity and for any signs and symptoms of inflammation or infection. Examine any drainage for amount, color, and characteristics. Observe the skin around the drain for signs of inflammation, and keep the area around the drain clean and dry. Monitor for edema, erythema, and drainage around the suture line, as well as any fever or elevation in the white count. The patient may actually experience phantom rectal sensation because the sympathetic nerves responsible for rectal control are not severed during the surgery. Be astute in distinguishing phantom sensations from perineal abscess pain. Sexual dysfunction is a possible complication of an abdominal perineal resection. Although the likelihood depends on the surgical technique used, the surgeon should discuss the possibility with the patient. Members of the healthcare team should always be available to address the patient's questions and concerns regarding erection, ejaculation, and orgasm, which involve different nerve pathways, and a dysfunction of one does not mean complete sexual dysfunction. The wound ostomy nurse is an important source of information concerning sexual dysfunction that can result from an abdominal perineal resection. So what do we need to teach our patient, wife, and family in regard to his post-op healthcare needs? We need to let them know that he's going to have some alterations in his stool and bowel movements. They will also need to be taught how to take care of his wounds. And they also need to know about dietary changes and for signs that they need to look for in the event of an infection or a future problem. Psychological support for the patient and caregiver is very important. The cancer could return. Patients need as much emotional support as they can get because recurrent cancer is painful, debilitating, and demoralizing. Issues surrounding palliative care, end-of-life preparation, and hospice need to be addressed. Patients who have colostomies need to know how to care for them. Even when patients do not have stomas, they may experience diarrhea, constipation, incontinence, or difficulty passing the stool, depending on which section of the colon has been removed and which surgical procedure was performed. Patients need to know about their diet, incontinence products, and strategies for managing bloating, diarrhea, and bowel evacuation. Often a combination of dietary changes and drugs can be used to help control diarrhea and constipation. Patients who have had sphincter-sparing surgery frequently experience diarrhea and incontinence of feces and gas. They often need antidiarrheal drugs or bulking agents to help control the diarrhea, but they also could overuse them and become constipated. They need to have a consultation with a dietitian that will help the patient and the caregiver understand how to choose appropriate foods that are less likely to cause diarrhea and odor and could help them discover which foods are problematic for them. Our expected outcomes is that the patient will have a minimal alteration in bowel elimination, balanced nutritional intake, relief of pain, and quality of life appropriate to disease progression, and an overall feeling of comfort and well-being. So what follow-up care will our patient need once he is healed from his surgery? He's going to need regular medical follow-up and screening for the possibility that this problem can occur again. He should also know when to be concerned and to call his doctor, such as when he has a change in his bowel routine, if he has abdominal pain, bleeding with his stool or from the rectum. I'm now going to review a little bit about your types of ostomies. I think I've already talked about this a little bit earlier, but please review this in your book from page 990 to 991. I'm also going to include an article that helps to talk about ostomy care and what needs to be done for that. You need to know table 4326 in comparing an ileostomy and a colostomy, what you're going to see, and where those can possibly and why they're possibly done. Thank you.